This video provides a step-by-step guide to hearing evaluation for medical students. Learn how to take a focused history, perform otoscopy, use tuning fork tests, and interpret findings to differentiate conductive and sensorineural hearing loss. Hearing loss is a common clinical complaint, and evaluating it properly is a core medical skill. In this video, we'll cover a systematic hearing examination, including history, otoscopy, bedside tests, and audiology. Exactly how you are expected to know it for exams and clinical practice. Step 1. History. Start with a focused otologic history. Ask about onset, whether it is sudden or gradual, laterality, whether it is unilateral or bilateral, progression and severity. Also ask for associated symptoms like tinnitus, vertigo, ear pain or discharge, or oral fullness. Important risk factors include noise exposure, ototoxic medications, recurrent ear infections, head trauma, and family history. Begin by inspecting the external ear for deformities, swelling or discharge. Next, perform otoscopy. Look for wax, foreign bodies or infection in the canal. Assess the tympanic membrane. A red or bulging tympanic membrane suggests middle ear pathology. A normal tympanic membrane is pearly gray, translucent and in a neutral position. Whispered voice test. Stand at arm's length behind the patient and whisper a sequence of numbers or words. Failure to repeat correctly suggests hearing impairment. Rini test is a tuning fork test which is performed by using a 512 Hz tuning fork. It compares air conduction to bone conduction. In normal or sensorineural loss, air conduction is better than bone conduction, whereas in conductive loss, bone conduction is better than air conduction. Weber test. In this test, place the tuning fork on the midline of the forehead. Sound lateralizes to the affected ear in conductive loss, whereas sound lateralizes to the normal ear in sensorineural loss. These tests help localize the type of hearing loss. Audiological investigations. Definitive diagnosis requires pure tone audiometry, which measures hearing thresholds across frequencies. A pure tone audiogram is a graphical representation of a person's hearing thresholds across different frequencies. X-axis shows frequencies in hertz, typically 250 to 8000 hertz. Y-axis shows hearing level in decibels. The lower the values, the better the hearing. Normal hearing is 0 to 25 dB. Conductive hearing loss, where bone conduction is normal and air conduction is reduced, which means there is an air-bone gap. Sensorineural hearing loss, both air conduction and bone conduction reduced and there is no gap. The common patterns include sloping, which is due to presbyocusis or age-related hearing loss. Notch at 4 kHz is usually due to noise-induced hearing loss, and there is a flat loss which shows conductive hearing loss. Tympanometry. Tympanometry evaluates middle ear function by measuring tympanic membrane compliance with changing ear pressure. Key parameters include compliance, that is mobility of the tympanic membrane, middle ear pressure and ear canal volume. In this slide you can see various tympanometry patterns. Type A mean the middle ear works right with a single peak and pressure between -100 and +100. Type AS shows stiff middle ear system, for example stiffening of the ossicles in otosclerosis. Type AD shows hypermobile eardrum, for example in ossicular dislocation. Type B, which is a flat curve, indicates fluid in the middle ear cavity or perforation of the tympanic membrane. Type C indicates negative pressure suggesting eustachian tube dysfunction. Clinical correlation. Pure tone audiometry assesses degree and type of hearing loss, whereas tympanometry identifies middle ear pathology. Together they provide a complete audiological assessment. Speech audiometry. Speech audiometry assesses hearing ability using speech stimuli, providing functional insight beyond pure tones. The key components include speech reception threshold, lowest intensity at which 50% of speech is correctly identified. Speech discrimination score or word recognition score is the percentage of correctly identified phonetically balanced words at supra-threshold levels. These help confirm the type and severity of hearing loss. Brainstem Evoked Response Audiometry, also called BERA or ABR, a non-invasive electrophysiological test that measures neural activity from the auditory nerve to brainstem in response to sound. Produces characteristic waveform 1 to 5 to assess the whole auditory pathway from the auditory nerve to the inferior colliculi. Clinical uses of this test include newborn hearing screening, detects retrocochlear lesions, for example vestibular schwannoma, useful in uncooperative patients, estimates hearing threshold objectively. Urgent ENT referral is needed for sudden sensorineural hearing loss, asymmetrical or progressive hearing loss, suspected acoustic neuroma, and chronic ear discharge. A structured hearing evaluation helps you localize pathology, guide investigations, and ensure timely referral. This is a high-yield skill for OSCEs, wards, and real-world practice. Like the video if it helped. Subscribe for more clinical skills content. Thank you.